What I'd like to do is have each person go and talk about the topic and the experiences of which we kind of have prepared. But then I think really opening it up for discussion and questions from you all, or if there's other experiences that we've missed, please add in. So going first will be Chidinma. So I won't introduce her again since she's already introduced herself. She's going to be talking in more detail about her work with community health workers and health systems. Next, Dr. Janice Bowie will be going. She's a professor in the Department of Health, Behavior, and Society. Her research focuses on health disparities and explores implications of religion and spirituality on prevention and treatment. And we've asked her to speak a bit on best practices for engaging churches to build sustainable relationships. And finally, Levine is an associate professor in the Department of Health, Behavior, and Society, and her research focuses on health promotion in underserved urban African American populations using community-based participatory approaches and randomized trials. And she'll be talking about the CBPR resources for early investigators. So I will have Chidinma start for us.
Okay, well, hi everyone. Good morning again. So as Kim mentioned, and I mentioned this earlier, a lot of my research interest centers around the use of community health workers to reduce disparities, especially cardiovascular health disparities. And so over the past few years, I've had some really interesting opportunities to work with health systems and community health workers here in East Baltimore with Johns Hopkins Health System. The first was so this is a little bit personal. So I've known Kim for a few years now. She helped me get my first job as a research associate at Johns Hopkins Healthcare. When I was hired by Johns Hopkins Healthcare, they brought me on to help evaluate a community-based care management program at the East Baltimore Medical Center. And at EBMC, they had a nurse care manager embedded at the clinic and then community health workers that were part of a broader collaborative care team. So when I went and worked with them, I worked really closely with the CHWs, with the care manager, to help kind of create this new program and then evaluate it. After that program was implemented, the Johns Hopkins Health System received funding from the Centers for Medicaid and Medicare, a CMMI Innovation Award. It was a demonstration project called the Johns Hopkins Community Health Partnership, or JCHIP. So JCHIP kind of advanced this collaborative care model, but at different clinics. And with JCHIP, they were focused on supporting care across the continuum from inpatient to outpatient, and then to other forms of outpatient care that I am not as well versed in. I'm versed in what I did. So we worked with these clinics, and in these clinics was a health behavior specialist, a nurse care manager, and again, a community health worker. So in that context, the community health workers were brought in to really address patient social determinants of health and provide additional social support. All the things that you may know, if you're familiar with the CHW model, they pretty much were consistent with the types of responsibilities that are associated with being a community health worker. And then after a couple of years into JCHIP, leaders within Johns Hopkins Health System forged a partnership with two community-based organizations, Sisters Together in Reaching and the Men and Family Center. How many of you have heard of these organizations at all? So these organizations are based here in East Baltimore, and STAR actually was on the west side for several years and then relocated to the east side. The Men and Family Center is right on Jefferson Street and has been there for several years, I think for over 20 years. And so in that new partnership, what they proposed was this multi-level model of community health workers. So at the Men and Family Center, they had neighborhood navigators who were in essence neighborhood block captains. They went block by block to figure out what residents of those blocks needed in terms of things like utilities, transportation, and other social circumstances that were affecting their health. So that's what the neighborhood navigators did for the Men and Family Center. And in that capacity, they were paid as part-time employee, or they weren't part-time, yes, they were part-time employees receiving a living wage, an hourly living wage. With Sisters Together in Reaching, they employed community health workers as full-time employees. And they were based at STAR, and or rather they received their training and oversight at STAR, and then were kind of deployed to different clinics who were part of the broader JCHIP initiative. So the role that I helped to play in that was, I was there from the very beginning when we started to talk about this program. And the program is called Tumaini, which means hope in Swahili. So it was really a grassroots, community-driven initiative that kind of got very systematically linked to the broader Hopkins health system in a really unique way. And in some ways, this partnership was a really good embodiment of the types of principles we talked about with CBPR. So we had leaders from the health system that valued the expertise that community members had. Then we had community leaders who had the expertise of having done similar work in different capacities, leveraging that knowledge and skill set to create this, community health worker hybrid model. And it was just it was an awesome experience. I don't really know it was awesome. I mean, it was one of the best experiences I've had here at Hopkins, and I've had some good ones. But this one was particularly good because it was the first time that, actually, my understanding is that it's one of the first times that the Hopkins health system actually gave money to community-based organizations to deploy interventions that were part of the JCHIP program, but I guess part of any type of program. So that was one of the unique aspects of it. The other thing that made it unique was that the conception of Tumaini was generated within the community. So what happened around the time of JCHIP's development was that the state issued a call for proposals to create health enterprise zones. The East Baltimore, a group of 30 organizations came together and tried to create the East Baltimore Health Enterprise Zone. And unfortunately, although they made it all the way as finalists, they were ultimately not funded. So they took the ideas that they came together with in the context of the East Baltimore Health Enterprise Zone and brought them to Hopkins and said, hey, we can help you implement JCHIP in a more meaningful manner that really gets into the heart of the different communities that are being targeted by this program. So it was really a coming together and just a really strong partnership with all these different entities, really building on the skills and capacities of all of the partnering organizations. And the way, I helped with thinking about its implementation, I helped to think about its evaluation, and I think one of the most rewarding aspects of it was being involved, was actually seeing the community health workers who got hired and seeing how much they enjoyed being able to help support members of the communities that they lived in. Because in the Tumaini program, they required that all of the neighborhood navigators and community health workers actually come from the Tumaini catchment area. So that catchment area was neighborhoods in 21202, 21205, and 21213, which are all neighborhoods right outside of Hopkins. So it was a great experience, and I think one of the biggest lessons that I learned from that experience is something I mentioned to someone I was talking with after our session, which is that to do community engaged work requires resources and commitment. It's not just, this nebulous idea of I want to make a difference, but you have to kind of put your money where your mouth is. You have to be willing to commit the personnel that are going to help support the infrastructure for the program. You also have to be willing to allot funding that will help even facilitate the process of partnership building. One of my favorite things about Tumaini is that we ate a lot. I really like to eat. Almost every time that we got together, there was a meal. I mean, I know it sounds funny, but how many of us build friendships over a meal? It's no different in stakeholder engaged research. And so, yeah, there was a lot of good food to be had during the Tumaini program. But in all seriousness, all of the meetings that we had together as a group with the health system leaders and the leaders of these community-based organizations really played a role in fostering a sense of trust and fostering a sense of respect that, I had talents that I could bring to bear, just as Reverend Hickman, who's the executive director of STAR, and Leon Purnell, the executive director of the Men and Family Center, also had to bring to bear to make the Tumaini program successful. That's it.
What she has described is absolutely so fabulous, and if David Levine were here, he and I both began our work in the community with this, using this community health worker model. And Chidinma has taken it a step further in that it is much more thoroughly and well integrated within the health system and within the community than we did. Ours was a little smaller. And we had challenges because nobody believed, including the state health department, who was funding us through NIH and the NHLBI, no one believed that you could have community people trained to measure blood pressures accurately. And so that was a huge challenge as we went out to do the kind of work that you're doing, which is outreach and responding to community and involving them in the whole, making them the leaders of the whole enterprise. Yeah. So I have a question. Have any of your community health workers gone on to get other jobs? Because that was one of our goals when we developed this. We saw this as the beginning of a career development for community health workers.
Yeah, that's a great question, because a lot of times in community health worker intervention, CHWs, there's no like ladder, career ladder, there's no career trajectory. And so when you think about creating those types of programs, well, okay, given that a lot of community health workers themselves come from disadvantaged communities, I think it's important to really be thoughtful about creating a career ladder. To me, that's actually an issue of equity and justice, that you can't just use them to do your bidding. You have to create mechanisms that allow them to progress in their own personal lives and their professional lives. So to answer your question, yes, there were a couple of community health workers. I think some of them may have already been in school while they were, working as a community health worker, and so that experience just strengthened them educationally in terms of what they were already studying. But I think there were at least a couple of people who went on and did like social work types of stuff, or well, social work, just social work types of stuff. But yeah, they went on to pursue careers in social work, or at least receive advanced training in social work. So
one of the rewards of having been around here for many decades is when you're walking down the street and someone will stop you and say, remember, I was the community health worker. I am now the surgical technician at Hopkins. She'd gone on and gotten more training, and it's been true for 90% of the community health workers. Many times it was their first exposure to the health as a health worker. But the big issue is, how do you train people and work with them and make them integrate them with all this, and have them be able to sustain their community centeredness and their neighborhood commitment, and not become the sort of paraprofessional of the health system, which is a nursing assistant, a social work assistant, whatever assistant. That was always one of the biggest challenges. So I'm sure you're facing that.
I think this transitions actually well to Janice's topic about sustainable relationships.
Yeah, so thank you, Lisa and Tangela and all of the faculty for inviting me. As Kim pointed out, that a good bit of my work in CBPR actually began through my relationships with faith-based institutions, and I was delighted to see your presentation because I having been involved in this work for so long, I think that you can start to take a little bit of a more cynical perspective about some of the challenges that go along with this. And so I always am a little bit suspect, for lack of a better word, of when we talk about CBPR, particularly in the context of faith-based institutions, I'm always focused on the P in CBPR. So the P is participatory, and I am always asking how much of a role of participating and partnering is actually going on in the work that we do. And so I'm also aware of when we talk about this work, if you hear people say I all the time, it's not likely that they're really doing community-based participatory research in an authentic way, because it rarely is ever I, it is we. And it is also not we and they. In my work with faith-based institutions, that a lot of community engagement has happened because, particularly in the Black church, historically, it was the place, the center, the focal point for community change, for social justice. And it is also the place where people look for respite to cope with the daily experiences of discrimination, racism, and other forms of social injustice. It is also the place where people find refuge and strength for all forms of historical trauma. And so this idea of engaging faith-based institutions in health is nothing new to the work that we do. This has been going on for a very long time. And so it doesn't mean that it comes without challenges, because there are many, many challenges. And some of the ones that I have encountered have a lot to do with our lack of understanding of how faith-based institutions work. They're very heterogeneous. They are not the same, even within same denomination. And all too often, we go to faith-based institutions because we think we can reach lots of people there. And while that is true, it is also important for us to understand doctrine. It's important for us to understand that context of how decisions are made, how governance happens within faith-based institutions, and that there is a hierarchy and a structure. So I want to share an example of, it's a bad example, but it was one that has been overcome. So I've been involved, and I am involved in a study that is now looking to take a trial and now looking to try to see how it operates under sort of real world, in the real world. And so we've been working with a number of faith-based institutions in a different part of Maryland. And this particular Saturday, we were at this particular church. And when I arrived there, one of our staff had on a skirt. And it was July, so it was the typical Maryland hot day. And but this was a Pentecostal denomination. And the point that I'm making is that if you don't understand doctrine, and this was just such a huge mistake that could have been avoided had doctrine and understanding of that denomination happened very early on. And so all too often we want to do work in faith-based institutions without taking the time to really understand and to build those relationships, which take an enormous amount of time and commitment. It is also that I am a strong believer that you can't do community work and not be in the community. You know, it just does not work. You can't be in the quote-unquote laboratory and then be engaged in this work. It is always going to backfire. How many of you have ever heard of Arnstein's ladder? So Sherry Arnstein was a sociologist and who actually generated a ladder, just like a ladder that you get on to clean out your gutters, or you should. And this is a ladder, she created a ladder of participation. And the rungs go from no involvement to maximum participation. And I always encourage my students to evaluate in the context of partnerships or advisory boards or steering committees, what does that level of participation look like? How many of you serve on a board or have ever served on a board? Do you know why you serve on that board? Have you ever evaluated your level of participation? Are you on that board, Thomas, because you are, you know, a male of color? Or are you on the board because you're a male? Or are you on the board because you're a physician? So sometimes you're on a board for tokenism. And that's okay as long as you understand why you're there. And sometimes you're on the board because you have financial means, like my colleague right here. No, I'm just joking. I was just checking to see if you're listening. Just checking. But my point is,
I can't even retire. My husband has me still working 12 years after I should have retired.
I told you should have got you a second husband. No, but my point is to understand whether you are on the end of creating this work, or you're on the end of being a part of a board yourself, to understand, why am I creating this structure? And what are the expectations for people who are a part of my structure? And make sure that people themselves know what you expect from them so that they can make an informed decision about why they are serving, what they're expected to do while they're serving, how long they expect to serve. If we're really looking to build partnership and commitment, it's critically important that you do that. What I see all the time in our institution is that we burden the same people all the time. We call on the same people. I can almost tell you, if I look at a picture, I saw Inez Robb on that picture. Inez Robb is on the Community Law Center board with me. She's on, because she is a person who is committed to the work, that's great. She makes the time, she shows up, she's reliable, all the things that you want. But it is important for us to expand and understand who we're asking and why we are asking them. And particularly in the context of faith-based institutions, we want pastors to show up at the meetings. Clergy have to counsel people, bury people, keep the lights on, all these sorts of things. And I have found that you want to communicate with them, you want their quote-unquote blessing, to be engaged, but to perhaps designate someone else within their congregations who will be the point person. You don't leave them out. They make the ultimate decisions unless they give that power over to someone else. But I'm trying to get you to understand three major things. One is to always check the P. And part of that is checking yourself and doing some reflection of, are you trying to shortcut the process? Are you trying to truncate the process? Are you just following the money? are you really authentically engaged in wanting to work, particularly with faith-based institutions? 2, you need to make sure you understand, respect, and listen to how these institutions work, what they think is important, what are their priorities, and how are you going to govern? Is it going to be a truly democratic process? Are you really wanting to make sure that you're building long-standing relationships, or are you in and out? Are you third, and I think this is so critically important, are you understanding what is sort of the end point? And what I mean by that is that we often engage with organizations that are truly social planning. Social planning operates this way. It says that I have expertise. I'm a PhD. I have expertise. My family says she has a PhD, which is probably true, whatever it means. But the point that I'm raising is that because I have this training and I'm considered some quote unquote expert, which I back away from all the time, I say I bring expertise, but I'm not an expert. But when you are a part of a social planning organization, I came out of 25 years being in a state health department. State health departments are social planning organizations. That means that decisions are made by people who have expertise. And those organizations are not set up for social change, by and large. They take the expertise and they bring it out and they say, I know how to do this, and this is how we're going to get the work done. And then we move on. We also, in academic institutions, are not always social change minded. We use that language. You saw it in the definition for Kellogg. But how many of us really get down the continuum to true social change? That also begs the question, do you really know what social change means? So I just want you to think about, in the context of CBPR, and I was so glad you pointed it out, Chidinma, it's fine that you don't engage in this work. It's not designed for us all to do it. I'm not trying to be a physicist. I'm not trying to be an auto mechanic. I'm going to stay in my lane and do what I do. And so my point is that it's fine if you don't do this. In fact, I would prefer that you not, because of the potential to do greater harm. And that then the people who really are interested in doing this work and engaging and working along with communities, when we are really trying to do this work, then we don't have to go out and repair the damage that has been created by others. So I don't mean to sound pessimistic, but I do seriously, really passionately ask you to do some self-reflection and to think about, what you're doing, why you're doing it, who you're doing it with, and are you able to really relinquish control and power and redistribute that with the communities, or in the case of faith-based institutions. So I'm done. I clap for myself.
She gave us a valedictorian talk.
I've never been a valedictorian.
How many minutes? We have 10 minutes. So, a couple things. One is, when I think about CBPR, because you've heard about what the principles are, and putting them into operation is the trickiest part, for sure. And it does have to do with how authentic you are, and how willing you are to say, I really don't know. I better listen to what the people are saying. And not only did I always need to be trying to listen, I needed to find people in the community who would serve as my coach and my guide. That would be a community leader. And I turned to Lucille Gorham, who's now unfortunately deceased. But she was the go-to person for the president of this hospital. So I thought, wow, she knows how to respond to the hospital needs. She knows how to collaborate and get other, quote, stakeholders or opinion leaders around her. She's the go-to person when the Baltimore Sun, the local newspaper, is looking for a story and a reaction from the community. She was the voice of the community. And I thought, wow, if I can have Lucille coach me as I'm trying to do the work that began in the late 70s, I've really got something to work with. And then I decided I also needed a politician. And we haven't talked about the politics of all of this. We all operate, and you talk about the principles of building good relationships, and that the principles of CBPR are really the principles of how you behave in the world. We're creating positive vibes from everyone. So we have to look to the leadership and look to the political leaders. So when we started back in the day, we began with the politicians. We began with the political leaders, and we're working out of mayor's stations. These are the decentralized places that the politicians have to be able to secure, when the elections come along, secure the votes that they need to win elections. And they're no dummies. They decided that they would set up these centers, and that these centers would have social services and all the collaborators. So I do want to say that so we had her telling us, and then when we went to do the same work in Sandtown, Winchester, which is where all of the uprising took place, we knew we needed to have stakeholders who were politicians. We needed stakeholders who maybe were going to be opposing what we were trying to do. We needed to bring them in and educate and listen to them so that we can incorporate their values and their agenda. And I'll never forget Reverend Tuggle saying to our collaborative group that was being organized around the Kellogg Project. Kellogg Project was designed to bring academia, practice, and community together. It was called the three-legged stool. And that was the mission of Kellogg in creating all of this CBPR work. That was the origin of it. So be wide, very wide in the selection.
What did Reverend Tuggle say?
So, excuse me, Reverend Tuggle said to the group, because we were entering a phase, which we haven't talked about today, of conflict within the group. And he said to the group, you know, you all have agendas. We need to start declaring what your real agenda is. In other words, why are you here today serving in this advisory capacity? And by the way, I have to tell you, for these meetings, you have to leave your agenda at the door. You're coming in here to be a collaborative group, and you can't have and serve only your own agenda. And we've only got 5 more minutes left. And so I think it's important that you all have a chance to ask us questions. So we are opening it up for questions. Yes.
Concerning the community health workers, so I'm wondering what the situation is here. I don't know if you know about asthma educators. So asthma educators used to be an entity that was not certified, and it wasn't reimbursed. And there was a campaign, and now there's a certification, and their services can be reimbursed. Is there anything like that for community health workers? Has there been a movement towards that to develop some kind of mechanism so that they can get reimbursed for what they do?
There has been a movement towards that, and I'll say what I know, and then I think Lee knows more than I do about this sort of thing. But so the first part of your question had to do with the certification process. So there is something underway statewide where they're trying to certify community health workers.
In Maryland.
Yes.
This is Maryland.
So it can be
Yeah.
reimbursable.
Yes, so they'll be reimbursable. And that process started a couple of years ago. I think there was some kind of work group that was, that came together, and actually some of the people affiliated with the Tumaini program were part of that work group. Lee was also part of that work group. They brought in different experts, whether they were experts in designing community health worker programs, community health workers themselves, or CHW supervisors, to provide some advice and insight into what are the core competencies that a community health worker should have. And then that would help shape the certification process. I actually don't know the outcome of that process, and I think talking about politics, I think something happened that kind of thwarted.
It's been delayed. The
yeah,
whole thing has been
it's been
delayed, and
pretty
I'm not
delayed.
really sure why.
I'm not sure either.
I think
politics
there's a
played
gap.
role.
I think there's a gap in leadership, and we haven't involved a very important partner, Medicaid.
Well,
Medicaid.
So CMS, does have its own work group
Yeah.
on community health worker reimbursement models.
Right.
And they're looking at a lot of different states that have actually adopted the model already. But again, this is like some long, drawn-out process.
Well,
that's
there are states
going on.
though
And there are
where it's
states where
been
it's already been
successful.
successful.
Yeah.
There are
Yeah.
8 to 10 of them.
Mhm.
Tennessee,
Mhm.
Virginia. There are other states. So it is very possible to do. The core competencies have been determined way long ago. The curriculum for community health workers, but then you say to yourself, well, they're going to have to get a degree or certification from whom? So who's certifying? Is it the state health department that's going to certify them? Or are we really setting them up to advance their educational achievements? In which case, you would want a community college to be certifying as they would a nursing assistant. Because the community college is going to be here forever. State to health department people delay. So we've got another question. So the point is, yes, it's in progress, and anyone who's interested should contact Juan Monroe, who's been kind of directing, kind of building the coalition of community health workers, building their own professional organization, a paraprofessional organization. Question?
What are the sources like for grant application, or do you recommend any like sources or good sources for community project grant?
Well, they are, many of the federal agencies
NIH?
are funding research and almost requiring that there be some form of community engagement as part of the structure. Some specifically will require the formation of a community advisory board or a patient advisory board. So the National Cancer Institute, National Heart, Lung, Blood Institute, the PCORI. So there are, one of the early funders was the National Institute for Environmental Health Sciences. But, now with...
That and NHLBI.
Yes, I said
Began back in the
NHLBI.
70s.
But now, and the National Institute for Minority Health and Health Disparities has also been a funder. So, I don't think that it's so much that the funding institutions, and certainly private institutions, are also sponsors of this work. So with the climate such as it is now, some of these things are sort of up in the air, but I don't think it's up in the air with specific to community engaged research. It's up in the air for everything. So enough and many of them are engaging in forms of social media now, and we have to take advantage of that, but we also have to understand that that's not true for all of them, and we have to make sure that that we still maintain some form of technical support for them. So one of the things that we found was that we just sometimes will make assumption that everybody has the same level of resources. They don't. And people are at different stages in this work. Some have very active health ministries, as you know, because you've been doing this work with the Black Church for a very long time. I won't say as long as me because you're half my age, but you know, which is still all fine. You know, I'm quite happy at this age. So I do think that we have to be mindful of how things are changing, how leadership in churches are changing. Some things are not necessarily changing. We still have many faith-based institutions that are male-led and dominated. And you know, we still have to work within those structures. And I just think that we have to assess and work with them, understand where they are and what their needs are going to be and what their priorities are. Some things like that don't change, the ways in which we approach, but the ways in which we implement and intervene may very well have to, you know, have some adaptation.
Yeah.
Oh, I'm sorry, you had to.
Right, we have time for one more question.
Okay. Can you two combine your question about Janice?
I hope you can hear my voice is a little bit better today, right?
Yeah.
I actually had two questions, but I'll try and see if I can compress it. Basically, I understand that you know, the goal of CBPR is to engage the community. But as you know, if you're a researcher, you know, professional, and you're trying to engage the community, and your point of view may not, or the topic or the area that you think may be important that you want to address may not be the concerns of the community. I just wanted to know how, you know, because okay, say I'm interested in maternal and child health, right? And if I go to a community and they may not think that, you know, maternal mortality is a major issue in that community, how do you, you know, yeah, how do you reconcile that? And two, sorry, I just wanted to add this. How do you, the sustainability of community-based, you know, approaches, how do you, you know, how do you evaluate it in terms of, you know, because a lot of these issues are long-standing cultural, you know, culturally ingrained in the society. So how do you, you know, I don't want to sound cynical or, you know, pessimistic, but, you know, encourage political will in order to change some of the, you know, the issues that contribute to the main problem.
So I'm happy to answer, but I don't want to bogart the conversation. So I don't know if you or Professor Bone, Dr. Ebe or Professor Bone want to answer it, or?
I have a thought. Well, first of all, those are excellent questions.
They really are.
And those are questions that I think anyone who engages in this kind of work asks themselves almost every day. And so that whole notion of reconciling what you think is important against what not against, but in comparison to what the community members or stakeholders that you're working with thinks is important is really challenging. And I think both Lee and Janice spoke to it when they didn't call it this, but humility. And so it really, when Lee talked about how Reverend Tuggle said that you need to take your agenda out and leave it at the door, I think it entails that sort of thing where you stop privileging what you think is important, and your notion of what is important becomes what the community members think is important. So as an example, I'm really interested in hypertension. To me, hypertension is critical. It's the second leading cause of death. But if I go out and talk to people in East Baltimore, I can promise you that blood pressure is the farthest thing from their minds, unless they're directly affected by it and had a stroke, like something acute happened that caused them to think that blood pressure was important. So that means that for me, if I want to be of service to the people that I want to work with, I can't tell them what I think is the most important thing. I can encourage them from the experience and expertise that I have, but ultimately, if they're telling me that violence is the thing that troubles them the most, or trash, or any other sort of thing that is, you know, kind of the opposite of what I'm thinking, I have to value that and go with what they think is important and not just what I think is important. And I think that's where the ego part and the agenda part come into play, and that's why I framed it as an issue of humility.
I do think that you can accommodate, oftentimes you can accommodate the priorities of that community, or they can accommodate your agenda. And so, and sometimes the population that you're working with may not be aware of the impact of maternal mortality. And so as you build the relationship, there will be opportunities for you to begin to share and to look for ways to try to accommodate. And there were times when you may need to, you know, bring someone in or try to find a stakeholder or engage with someone who can help them deal with the problems of trash. Because maybe when trash is dealt with, then that frees them up to begin to think about what might be some other issues that you can share. And I have always found that when I have sought funding, so I had sought funding for a particular study, and that study was to look at 3 kinds of cancers. And the faith-based institutions were very interested in some other things. And I said, well, wait a minute. And the clergy said to me, look, we are really interested in, you know, these other things too. Can you accommodate those? And then I started to think about it, that many of these same issues around nutrition, physical activity were connected to these cancers. So that was a way to accommodate them, as well as to also address these issues of the 3 cancers. So I know we're out of time, but I didn't want to, I wanted to make sure that you understood that it doesn't always have to be all or nothing.
Which we haven't really talked about, which is the fact that you, through your networks, what does the community really want? They want your commitment, your authenticity, and they want connections to the resources. This is the other thing that Reverend Tuggle said to us when we were doing the Kellogg Project. I said, why are you interested? Why do you want to participate in this? I know you want to contribute, but why is it, other than getting the resources from the Kellogg Foundation? And he said, I want connections with the resources at Hopkins. And I said, well, you have them. You've got faculty that we're working with, and we're doing this. And he said, no, you don't understand. I want to meet with the dean and the president, and I don't want to just deal with faculty or people that are very interested and committed to this. I need to be where the power is, was what he was saying. And he said, and until you can make that happen, and if you he challenged all of us, if you can't make that happen, then, you know, you could go home. because I'm not gonna play with you in the sandbox at all. So, and that did happen, and it's and I can tell you, Al Sommer to this day remembers when Reverend Tuggle and the other pastors came to his office with their requests. So there are a lot of sort of tricks of the trade, if you will, that are, or tips that we ought to put that into writing.